this is unrelated to diabetes actually. So A is the A1C. So you have to target A1C of your patients. You have to target your blood pressure of your patient, and then you have to control cholesterol. And I think Dr. Mohammed Hassanin already showed the picture with the orchestra there that indicates that it's not only diabetes treatment, it's the other things which are actually important. So, very important point we usually don't ask before our patient whenever they come to our clinic. And it's this very important point, which is you should ask your patient about their current treatment of diabetes, medication, and if they're actually adherent to the treatment, meal plan, physical activity, and of course, a very important thing is about the hypoglycemia. And if the patient could actually develop hypoglycemia and awareness or not. So many times we actually upgrade the treatment of the patient based on not asking the patient. The patient comes to the clinic, you see the patient's A1C high, and then you just increase the doses of the patient without actually asking him if the patient is actually adherent to the treatment or not. So it's very important, are you taking your medication? It's easy to ask the patient to know if he's actually taking the statin therapy because the LDL will be low in most of the time. But let's say the patient's A1C, when you ask him, did you take your medicine? You'll be surprised with the amount of patients who's actually not taking the treatment, even the frequency of taking the treatment in those patients. So going through the history of management of diabetes by a case, so let me start this theoretical case with you. So if I have a 50-year-old male diagnosed with diabetes type 2, seen in your clinic to evaluate his diabetes management, his BMI is 31, his A1C is 9.2, his LDL would be 4.2, so how do you manage this patient? If I ask and I give you a sheet to write your management, all of us will be different. I bet you it's all going to be different. But let's go through the history. So if this patient was actually seen in 1960s, the only available drug at that time was metformin, sulfonylurea, and insulin. And target A1C actually at that time was not recognized. If you look and treat this patient in 1970s, still metformin, sulfonylurea, insulin possibly start targeting A1C. And I know Dr. Mohammed, of course. And then if we look at 1980s, for the same patient, then metformin, sulfonylurea, insulin, and target A1C was there. So 70s, 80s, they're almost the same. 1990s, then we start having the alpha-glucosidase inhibitor. TZDs were there. And of course, target A1C below 7%. Before, in the 80s and 70s, they identified A1C, but they did not actually tell us what A1C the patient should be on. But in the 19s, then we start to target an A1C below 7%. In the 2000, of course, we have all of those groups. And of course now, after 2010 and current time, we have all this number of medication that we can use with our patients. So in a simple word, if you have susceptibility and you have a bad lifestyle, then this will lead to insulin resistance. Eventually, the patient will have impaired glucose tolerance, eventually type 2 diabetes. It was thought initially that it was actually a matter of insulin resistance, just a matter of insulin resistance with type 2 diabetes. That's, if you look at the old textbook, you will see that this is actually the pathogenesis of type 2 diabetes. This is Dr. Walid, just this part, stick to your part. But of course, it's actually more. It's all this mechanism that actually can cause hyperglycemia. And now that we have almost a drug for each target organ that we can use with our patients. So, and of course now is the kidney, which I'm going to be talking in the second lecture. So let's talk about the visceral fat. So this is a typical type 2 diabetic on the right side here, and that's a lean patient. So if you have, just in a simple word, if you have kishmish, raisins, what if you accumulate fat, this is what happens. Visceral fats, it's like raisins. If you gain weight, this is what happens. You don't lose the amount of fat, you shrink the fat cells. But this is what actually happens with time. So what causes visceral obesity or visceral fat accumulation? Overeating, smoking, increased alcohol intake, lower energy consumption, genetic factors, and of course, as we age. And insulin resistance, the same thing, use of certain medication, Cushing syndrome, pregnancy, PCOS, and name it. How about insulin secretion? If you have reduction of postprandial, which is the first phase effect on type 2 diabetic patient, this will lead to eventually postprandial hyperglycemia, then eventually a decrease in pancreatic beta cell mass. How about the kidneys now? So we know that I'm going to be talking into more details about type 2, this group in the next lecture, but kidney is now actually plays a good role in the management of type 2 diabetes. So the problem is we are treating our patient too late. We're seeing them when they're actually diabetic, when it's actually we have to see them before being diabetic actually. We have to see them in the pre-diabetic stage. Because we know that if you are a pre-diabetic patient, you are at increased risk of developing microvascular disease. So this means you shouldn't delay the treatment, and you have to act now rather than later. So what about the clinical inertia that I was trying to explain in more detail? So in physics, the inertia means resistant to movement. In medicine, is resistant to change. So it's a very common problem in the treatment of type 2 diabetes. And despite the availability of more diabetes therapy than even before, almost half of those treated still have difficulty controlling their blood glucose. It's not only patients' reluctancy to change medicine, it is the behavior of the physician to change their practice with the patients. Meaning, physicians are actually afraid because of this hypoglycemia, blah, blah. I know you have to measure and look at all the variables with your patient, but it's very important not to delay the treatment if the patient is requiring it. So, for the definition of clinical inertia, for those recently diagnosed with type 2, it's failure to start treatment at the most appropriate time, which is in the beginning of the diagnosis of diabetes, which everybody is trying to emphasize, that you have to be very harsh, very aggressive from the beginning. Diabetes, cholesterol, sugar from the beginning. And the other problem of those who are actually receiving the treatment is when the treatment is actually not escalated, which means you know that the patient requires upgrading of the treatment, but we have problem is actually upgrading the treatment for the patient for many reasons, whether it's resources, whether it's the patient acceptances for the new medication, or maybe the physician lack of experience with the new medication to give it to the patients. So clinical inertia should start from the time of the diagnosis. So when you look at the key principles that should be done between the patients and the physicians, is that very important that you have a good communication with the patient, telling the patient what's the problem and what possible complication will happen from the beginning of the diagnosis. It should be a realistic approach for the patient. So if the patient is, let's say, working as a driver, cannot really take certain medication, there is risk of hypoglycemia, you have to be very realistic with this patient in terms of treatment option. Individualization care needs. So two patients are not the same. Different patient has different approach. And of course, it's very important that you intensify the management of the treatment without delaying the treatment of your patient. Very important from the beginning with the diagnosis. So patient perspective, this is a very interesting thing. So when they talk to those patients, newly diagnosed patients about diabetes, around 63% that it will affect their future. Only 25% were devastated that they might develop complication. Almost 10% were not concerned that they have diabetes and problem with their diabetes. And 3% actually did not care about anything. When you ask the patient, what's the most fearful thing about having diabetes, 50% of them were actually telling you that they're afraid that they will lose their vision. 20% had heart problem, 11% has kidney problem, 10% circulation, 10% foot, and 7% other. So you could see it's not only physician perspective with the management of diabetes, it's patient physician perspective with the diabetes. And most probably, whenever you deal with the new patients in your clinic and you ask him, or you tell him that you have diagnosis of diabetes, he would tell you, so now what? I'm now officially I'm Kuwaiti, because they say that Kuwaiti people has a high prevalence of diabetes. So important to understand that every person with diabetes is different. None of them is the same. And you have to emphasize this issue even for your patient whenever they go to their Diwaniya to tell them not to change the treatment without going back to you. And there is an obligation on every person with diabetes to accept responsibility for their disease, and of course has a good support from their family and caregivers. So, very important for living with diabetes, 4-step pathway to improve health for the person with diabetes. It's that the patient, communication, different patient, obligation, and if you don't able to achieve your treatment from the beginning, you have to upgrade your treatment. Don't wait too long. We have a say here in Kuwait, maybe after Dr. Walid in his lecture will translate, إذا فات الفوت ما ينفع الصوت. إذا فات الفوت ما ينفع الصوت. So if, I don't know what's in English, I'll try to think of an English version of it by next lecture. Oh, yeah, almost similar. So for every diabetic patient, identify the problem, set the therapeutic goals, and initiate and intensify treatment as required for those. Thank you very much.
So thank you, Dr. Talal, for your excellent lecture. So we'll open the floor for questions before we go to the second lecture. Any question? إذا فات الفوت, no more questions. So we'll go to the next lecture by Dr. Talal too. Okay. So we can let him go then.
So I tried to find a new topic, calling this topic. So if you look, this is a very interesting book called The New Kid in the Block. It's about poems, and you could see that this boy is seeing himself as different with other boys in a way. So I called this lecture The New Kid in the Block, which means the new drug in the field of diabetes, in a way. So I always like to present a picture of the past. So what do you think? I really find this picture very fascinating. So this is like one of the earliest patients who are actually treated for diabetes. And you could see that his wife is actually trying to help him. You could see her face expression. She's actually trying so much to help her husband. But even the technique, if you look at the technique of injection, is maybe we don't accept this technique at that time, at current time, but at that time could be very accepted. I don't know, 30 degrees this or 20 degrees. Anyway, and that seems to be the poor husband is accepting the faith of his wife giving him the insulin. So, anybody knows what's a water taster? What's a water taster? So a water taster, I think I might mention this before. So a water taster is, before diagnosis of diabetes was actually made by water taster. So the water taster were actually people who were actually drinking the urine of the patient, because, you know, because of the amount, yeah, I know, I'm just saying history. Don't feel disgusted about this thing. This is just a history. I'm telling you, we're blessed now. We have all this kind of new gadgets, new things to diagnose diabetes. But before this is true, they were tasting the urine to see if this patient actually has diabetes or not. Anyway, that's part of history. We have to accept. So, let me start this case with you. It's actually windy today, but in a dusty day. So, well, it was usually a busy clinic. You know, sometimes you sit in the clinic, this weird consult comes to your clinic, and I received this consultation about a patient who's 60 years old, male, who's non-diabetic for almost 16 years, so almost at the age of 50. So he doesn't know his medication, which is actually with almost 50% of our patients. They'll tell you the white pill, the blue pill, the red pill, whatever pill is there. And he just came back from treatment abroad for ischemic heart disease. So he already developed complication from diabetes. And he was actually referred for possibly poorly controlled diabetes. So he recently noticed that he slightly goes more frequent to the bathroom. And if he used to go 4 times, he was going 5 times, 6 times, 7 times than he used to do before. And he also lost around 3 kilos. So, and when I examined his blood pressure was around 110, and the rest of the exam was actually unremarkable. Of course, when a patient like this comes to your clinic, we think of polyuria, polydipsia, weight loss. So you would think that this patient could have a poorly controlled diabetes, right? So this is what I thought initially. So I did an A1C. It was 6.7. I said, it doesn't match really. A1C, polyuria, polydipsia. I said, maybe this is he has some of the disease that might actually affect his A1C. By going through the history, he doesn't have any evidence of any other disease that might actually gives him a low, artificially low A1C. His LFT, RFT is normal, no albuminuria, and his urine analysis actually shows 2+ sugar in the urine. And I said, you know, yeah, possibly that's something, negative protein. I said, yeah, there is something iffy with this patient. There is a problem with this patient, actually. So what's next? What would you do with this patient? I gave him the logbook, and I told him to check his sugar. All of his sugar readings is 5, 6, 7. So why he's going to why he's developing polyuria, polydipsia, weight loss? Okay, I said, okay, I was very, I went sophisticated and I said maybe diabetes insipidus because they could have polyuria, polydipsia, but there was no evidence that he has diabetes insipidus at that time. So we looked through the medicine and we knew what's the problem. Well, not the problem, actually the reason for him having polyuria and possibly polydipsia, which is actually not polydipsia, and why he's having weight loss. So is sugar in the urine is bad? Do you think seeing a sugar in the urine is bad? If we look previously, yes, if sugar in the urine before is bad, yes, it's bad before. But maybe not at all at the end now. That sugar in the urine is not bad. I could see some people actually nodding their heads, agreeing with me. So when sugary urine, I call it sugary urine, is not bad at all. So let me tell you about few facts, very important few facts that the patient actually might come and ask you in their clinic. Doctor, why my sugar in the morning is always high? Rest of the day I have no problem. Morning time is always high. I did not eat a lot of food yesterday night, so where is this sugar is coming from? So if you look, 80% of the sugar in the morning is actually coming from the liver. And 20% of the sugar is actually coming from the urine. And around 10% is actually from what the patient ate before. So, this is important? Yes. Because if you look here, this is just to give you how much of each organ. So if you look here, in the hepatic, the liver, through the glycogenolysis, there is around 45 to 50% of the sugar through glucogenolysis of the liver, and 25 to 30% is through gluconeogenesis of the liver. And if you look at the renal, I told you 20%. So from the gluconeogenesis, there is around 20 to 25%. Very important. So renal gluconeogenesis and renal glucose uptake and tubular glucose reabsorption are the three ways of renal involvement in glucose homeostasis. Very important. So actually the kidney could actually produce sugar. And if you look at the literature, if you look at old literature, that they tell you that the idea of kidney involvement was there actually from 1930s. And if you look at the kidney involvement, release of glucose, like I said, from gluconeogenesis, uptake from reabsorption, and if you look at the sodium glucose co-transporter, which I'm going to be talking about in more details, what is very important for us is the SGL2 inhibitors, which is exclusively found in the kidney, which are the ones are responsible for glucose reabsorption. So I want you to understand this fact because I'm going to be talking about a very important point at the end. So at the SGL2 receptors, the glucose, because it has a high capacity to the glucose, it will take up the glucose and then release it outside. At the same time, sodium goes out with it. Why important of sodium? This I'm going to be talking about it shortly. So if you look here, it's the same thing. You have an SGL2-1 and an SGL2-2. SGL2-2 has a higher affinity for sodium, if you could look there. The other one is high affinity for glucose. Why it's very important in diabetic patients? Because in patients with type 2, there is a higher expression, so there is actually more SGL2 receptors, okay? And there is more reabsorption of glucose in patients with diabetes of type 2. Very important point. And do you know when the patient will start having polyuria, polydipsia in your diabetic patients? Without even checking the sugar of your patient, do you know when they usually start having polyuria and polydipsia? It's there, when the blood glucose is above 10 millimole. The glucose reabsorption capability of the kidney to reabsorb sugar is up to 10 millimole. After 10 millimole, all of this will be released in the urine. And the patient will start having polyuria because of the osmotic diuresis of the glucose. In type 2 patient, they have a higher threshold of renal excretion. So rather than having it at 10 millimole, they'll have it, let's say, at 13.9 millimole. So this means that they have a more reabsorption of sugar compared to non-diabetic patients. Did you get the point? So normal non-diabetic patient, glucose reabsorption 10 millimole, anything above 10 millimole, patient will start having polyuria. In patient with diabetes, the renal threshold of glucose excretion goes above, so they have more of glucose reabsorption. So, and it's a vicious cycle. So they have hyperglycemia, glucoseuria, they have more expression of SGL2, and it's more glucoseuria. And this puts more fire into the hyperglycemic thing with the patient. So a very interesting point. If you have an SGL2 and you inhibit SGL2 inhibitor, the insulin level usually goes down, and the insulin-dependent tissue glucose uptake is maintained because there is less glucotoxicity in those patients. So this is what you want to, sorry. So kidney role now in the treatment of type 2 diabetes. So I told you in the early 1930s, they described that the kidney has actually role. But if you look at the old literature, florazine, which is a bitter white glycoside isolated from apple tree, was actually used to treat patients with polyuria, polydipsia at that time. and it helped to lower down their sugar. So it's actually even before the development of insulin. But it was very highly toxic with so much side effects, did not really actually get very popular at that time. So for centuries, the kidney has been considered primarily an organ for elimination and regulation of salt and iron balance. But now it plays a major role, about 25% or 20% of the regulation of sugar. So if you look here, you would see, this is to tell you how much sugar is required by each organ in our system. And you see that reabsorption, just now I told you 10 millimole, which is around 180 milligram per deciliter, which is the renal reabsorption of glucose. Anything will go outside. So what happens if you block that system, the SGLT2 inhibitors? So if you block the SGLT2 inhibitors, more sugar will go into the urine. So let me show you what happened actually here. So if you block SGLT2 inhibitor and if you take sugar, everything will go where? Through the urine. So this is actually what happened. So anything above will go. And the interesting thing about the SGLT2 inhibitor that they actually try to bring down the threshold of renal excretion of glucose to around normal. So because I showed you that diabetic patients with type 2 have a higher renal threshold for glucose reabsorption, with the SGLT2 inhibitor, there are actually some studies that shows it's actually lower down the the renal threshold of glucose reabsorption. So if you look at the guidelines, where is SGLT2? They only introduced SGLT2 inhibitors this year of 2015. And different guidelines look at it in a different way. Just to show you something which is there, what's different between SGLT2, maybe it's difficult for you guys in the back to look and appreciate, but let's look here at the SGLT2. Look at the SGLT2 inhibitors. You can combine it with all oral agents except injectables, which are the GLP-1s. If you look here, if you look at the SGLT2 line, this is according to the ADA, yet